Those out there listening, welcome to the Corona Initiative in Otolaryngology. We're the third consortium for ENT resident education that's been started. There's the West Coast, there's the Great Lakes, and there's the Eastern. And this first hour is going to be a little bit of a hybrid. We're going to do an update on the COVID-19 activities going on around the country and internationally. And then also, we're very blessed to have someone who's kind of boots on the ground, front line right now from New York City. Make sure I can, just a second. Okay, so nobody has any disclosures. Today's schedule, we'll start with this hybrid lecture. And then Dr. Fritz from here at UK is going to talk about chronic cough. Dr. Montravati from IU is going to talk about oral cavity reconstruction. Then Dr. Gray from Mass Eye is going to finish the morning with avoiding FEST complications. So a couple housekeeping issues. I realize at this point virtually everybody's been on Zoom before, but if you haven't, please remember to mute your mic and ask questions via the chat option or at the end during the Q&A. Decide whether you want people to be able to see you on Zoom. We currently are well under our, let me double check. Yeah, we're well under our licensing max, but if you hear of anybody not being able to log on, please have them let us know. That would be a licensing issue, and the lectures will be recorded. My assistant, Sarah Buck, who's helped facilitate all this, is she's working on splicing lectures. She was doing that this weekend, so we'll get them up, the links up on the website. And then tell people about the consortium. So first thing we'll go to is just the update on COVID-19. We have three panelists. Dr. Nikita Gupta from here at UK, she's our Associate Program Director. Dr. Alex Keckner, who's also from here at UK, she's one of our head and neck free flappers. Both of them have connections both to New York City and then also internationally. And then we have Dr. Damia from New York City, who's been gracious enough to join with us. And I want to stress that the opinions given this morning are of the panelists, not necessarily of the institutions for which they work. So first of all, thank you for joining us. Dr. Damia, I wanted to start with you and wonder if you could kind of give us, for those of us like myself who haven't spent a lot of time in New York City, can you give us a kind of a gestalt of what's going on there, what you're seeing, what it's like to work in the hospitals right now?
Yeah, definitely. Thanks, Brett. What I would say is that it's pretty variable across the city. Every hospital is getting pretty slammed with patients, but there's certain hospitals that are better equipped to deal with the wave than others. I would say that probably the major institutions in Manhattan themselves are the best equipped, but even at those institutions, there's conservation of resources because even those resources are limited at, over there. But a lot of the other boroughs, especially Queens and Brooklyn, are getting hit pretty hard. And there's a pretty significant lack of PPE. There was a New York Times article, I don't know if people had seen it, specifically on Elmhurst Hospital. But there's multiple hospitals like Elmhurst in the other boroughs that are really suffering. And as this is progressing, you know, our census is increasing. They're actually starting to build. They're building makeshift morgues with tents and refrigeration trucks around the city in preparation because a lot of the morgues are already getting pretty full. To actually store any excess bodies. And lots of hospitals are also building beds. There's one institution that's building beds in their lobby, and they're also building a field tent in Central Park itself to deal with the wave of COVID patients. So it's pretty significant. When I say pretty significant, it's very significant here. New York City alone, as of yesterday, had about 34,000 confirmed cases. And about, I think it was something like 600-700 deaths. So, and we're still about 2 weeks away. They estimate for from our peak. So it's going to continue to get worse until it gets better.
Wow. Okay. I'm a program director. So tell me about your residency crew. How how they're working in this. You know, here we've gone to platoon system. How are you guys dividing things up? How's that working?
Well, well, a few things. One, a lot of our attendings are trying our best to try to minimize exposure for our residents, but while also maintaining education, because I think it's still important, because this is something that they're probably never going to see ever again in their lives. Sure. But we have to balance education with exposure. And so there was actually a number of residents that actually got sick. And so before the whole wave even really came to be. So we don't necessarily depend on our residents to be a part of the workforce, but the way that they've been helping out is they've been taking shifts on helping to cover the ICU. We have like a specific team that focuses on intubations, placing central lines, arterial lines, vent management, and actually proning patients. But again, like when it comes to the highest risk events, airways, we don't let the residents touch the airways. That's completely attending mediated. Other than that, we still obviously have urgent emergent cases that our residents will be a part of. We still have a busy labor and delivery service, so residents are still contributing to that. But their duties are being pretty significantly split.
Is there anything, you know, you have a number of otolaryngology residents watching right now. Is there anything that you feel would be beneficial for people to brush up on in terms of maybe critical care background reading or anything like that? Because I feel like the wave is going to come here to Central Kentucky and elsewhere, and perhaps we need to preemptively get our knowledge base back, you know, third, fourth year medical student type of knowledge from being on an ICU rotation or something. So any aspects that way you could think of where we could be beneficial as backup physicians, so to speak?
Yeah, I mean, I think the biggest things are, because you're dealing with it's pretty uniform in regards to the pathophysiology. I mean, these patients are going into ARDS, and you know, some are going into organ system failure, but the majority are, you know, dying of respiratory failure, et cetera, and potentially superimposed infections, et cetera. So really, I mean, ARDSnet, you know, because the thing is, if you're going to start managing, usually you're going to be still with an ICU attending, but, you know, reading up on ARDS, the pathophysiology of that, in particular, vent management strategies. I don't know how it's going to be at your institution. At our institution, a lot of the vent management is being primarily done by the anesthesiologists as well as the intensivists. And the residents are serving kind of as backup, but they're not generally making those types of decisions. But I think just in terms of understanding the pathophys of ARDS and understanding like kind of how decisions are made based on that is probably going to be the most useful.
Excellent, excellent. And for the residents and or faculty who are out there listening, please, if you have questions, submit those via the chat feature, and I'll kind of edit those and then we can go through them. So I want to move on to Dr. Gupta and Dr. Keckner now. I'm wondering if one or both of you can give us, just kind of rewind a little bit, give us a little bit of background on the COVID-19 pandemic, you know, how it started, and how we've gotten to this point. And then we'll move on to down the road a little bit more specific otolaryngology related type things in terms of personal protective activities and things like that. So could one of you start and just give us a little more background on the COVID?
Sure. And I just want to say, you know, thanks to Brett for putting this together. It's a huge amount of work, and I'm really excited about it. And I think it takes a lot of heat off of the individual institutions, which is really nice as we kind of enter this unknown territory. So yeah, everyone's been reading everything every single day, every single minute about this. But just in general, it's a novel coronavirus, kind of like the other beta coronaviruses like SARS and MERS. It's zoonotic, and it's thought to have originated from, I think, bat RNA in Wuhan. I'm not sure. Initially, it was thought to be related to that market I guess we're not sure now. It rapidly spread as humans didn't have like a natural immunity from previous exposure, like with other viruses, like flu, for example. We've been exposed to other types of flu in the past. And then there's a range of symptoms from mild to severe. So unlike something like Ebola, which has a very high death rate, it since there's so many mild and even asymptomatic cases, it can spread very quickly. And there's really some great maps online on New York Times and things. You can see how quickly it spread out of Wuhan. Wuhan, you know, was right around the time of Lunar New Year when they had to shut it down. And I think one example I heard was that it's sort of like shutting down Chicago at Christmas. It's a sort of like a hub, a travel hub, a lot of people coming in and out, and that's another part of why it was able to spread so quickly, and then from there to other parts of the world. So,
yeah, and I think one of the kind of hallmarks of this kind of thing is that as people have expanded their kind of reach into the world, we're seeing more of these zoonotic types of infections. So the thought is that because we're encroaching on different habitats, we're seeing, you know, animals that we wouldn't necessarily see very easily. And from the original SARS virus, they actually went in and mapped out various viruses from the bats that they encountered in these little remote caves and places like that, and were able to find kind of the main culprit. The problem being then that because people are moving around as well internationally and globally, we then can easily spread it. And the other kind of scary hallmark of this one is the asymptomatic shedder. And so if you saw the article about patient number 31 who flew from Wuhan to South Korea and then managed to infect something like 3,000 people, basically getting on a plane, going to a wedding, going to a funeral, and then going to the hospital. And in all of those interactions, shedding virus. And so what we're seeing is that it's concentrated primarily in the nasopharynx. Currently, there's still some debate as to the droplet versus airborne question. Initially, it was thought that it was primarily large droplets. And so sneezing, coughing, vomitus, nose blowing, and then, you know, wiping your nose and touching something. There is some thought that in instances where there's forced exhalation of any kind, so if you think of people shouting or singing or being in close quarters while being loud, could potentially also sort of jet propulse these viral particles into the air. And so there was a story coming out of LA, or the LA Times, I'm sorry, that was in just outside of Seattle. A group of 60 choral singers were practicing together. They didn't touch each other. They stood far apart, but they were all singing, and 45 of them came down with COVID. So this sort of underlines the idea that, one, we should continue social distancing, but also coming out of the CDC soon is going to be the sort of widespread general public use of just the regular kind of like cloth masks and things like that. Now, it's a huge issue because of the lack of PPE we have available right now. And Manoj can probably talk a little bit more about that on his end. Fortunately, we here in Kentucky have not had a huge issue with it just yet, but we're already starting to ration. And, you know, anytime you say, hey, everyone needs to be wearing masks, then you have this huge inundation onto Amazon, eBay, Alibaba, you know, wherever, buying surgical masks, or people taking them from, you know, from the hospital with them. So,
Excellent. And with regards specifically for the otolaryngologist, you know, as a rhinologist, some of the information that I'm seeing on the discussion boards and blogs and things like that is disconcerting. So if we look at specifically with otolaryngology, what are the most recent recommendations? I mean, even as of this weekend, what should we be doing?
I think in general, remembering that the nasopharynx is where the highest viral load is, but it's still, they're even talking about how some tests can possibly be positive at mid-turbinate or anterior nasal cavity. And just like Alex said, any kind of aerosolizing procedure. So even just putting spray for a scope, doing the scope that might encourage them to cough or blow their nose or sneeze, which they cannot control. Obviously intubation, any sort of airway DL procedure, different institutions have different protocols. The Academy now this weekend came out with guidelines for trachs, and part of it is we still don't quite know with this disease how much trachs will be useful, necessary, but they're very high risk, not only for the team performing the procedure, but for afterwards. Alex will talk about this more, but we're also, even with elective cases, we're talking about, and by elective, I don't mean elective, I mean urgent, emergent, or like these laryngectomies, testing patients ahead of time for COVID, because that would be a very high risk both to the patient and to the team operating, as well as taking care of them for that next week or so in the hospital. So I guess in general, we're trying to prevent and limit those procedures unless absolutely necessary, and when they occur to wear the correct PPE. And that's not just an N95 or even a PAPR and some of those like transnodal type cases. It's also hair cover, face shield, shoe covers, gown, the full deal. And then the main other issue that we don't really have an answer to is if you're not doing it in a negative pressure room, which most of our rooms are not, what happens in the air afterwards. There's talks about like it kind of lingers in the air for about 3 hours, but then there's data from one of the Princess cruises where they found RNA within those rooms for days. So a lot of it is unknown, but the most important thing is, particularly for residents, if you do happen to be in these situations, to protect yourself. And make sure that you have the adequate PPE before going into doing anything and deciding if you absolutely need to do that. And that's often when you want to get an attending involved early, and maybe that's the person that actually does the procedure and doesn't put more people at risk.
And to kind of underline that, we are trying to come out with some more solid recommendations out of the AHNS and collecting data institution-wise in order to see kind of what people have come up with regards to their measures that they're taking in various places in order to sort of inform maybe one policy across the board. One thing that has come up several times is that chlorhexidine is not a good preparation for these patients. Usually at least a 70 to 80% alcohol preparation or povidone iodine. And it has been suggested in some smaller studies to use as a nasal preparation or oral gargle preoperatively, like as a prep when you're going to be doing some type of aerodigestive cancer case. But one of the things that at least from my side of things, I would be very interested in, because sometimes we, as otolaryngologists, we just kind of get called for the trach and we say, okay, well, what's their PEEP? Can I do it? So Manoj, have you seen, what's been like the situation from like doing trachs, or is it helpful? Is it getting people off of vents, or is it just something that you should see what the prognosis is? Or
I think a lot of times it's, we do have some trach patients. And I think for one of it is just because the prognosis isn't great. So they ended up doing a trach, and we actually got called in because there was bleeding around the trach site, and they thought it was actually muscular bleeding. So we actually had to go in and intubate from up top, and then they had to, obviously stop the bleeding, and then they were going to go back and deal with the trach. But again, like high risk events, one thing I would say is, obviously, the trach was in, so we were able to ventilate through the trach, so we had time to intubate and do everything on that end. But I think things that we kind of take for granted is, a lot of these patients, not in this particular patient, but a lot of these patient population before they get intubated are going to be, a lot of institutions are instituting like high flow nasal cannula, and 100% non-rebreathers, because they're trying to minimize time to vent. A lot of these patients end up on a vent regardless. They end up getting intubated, but you want to try to minimize it just, again, to conserve resources. But that's one place where you can get exposed. So that actually happened to me. We were intubating. I helped take off a high flow nasal cannula before we were actually securing the tube, and the attending, not her fault, but she did it. She placed it on the bed, and the high flow nasal cannula blew right in my face. And I had my face shield on, my mask, my N95, but it got kind of in between because it wasn't full headgear. It wasn't a PAPR. And so because of that, I started, my institution instituted a prophylactic protocol in that case. And that happened well over a week ago and I'm not symptomatic. So, so just being really, really cautious that, you know, if you're going to be manipulating, if you're going to be removing those, because those things are particularly getting in your way, make sure that the flows are completely off before you do it, just to try to minimize the risk of exposure. Same thing if you do have a patient that has a trach and you need to disconnect the vent for any reason, making sure the vent is turned off before you disconnect. All of those things are going to minimize your risk of getting exposed. So just being very, very cautious of those things.
What is the protocol for if you're exposed at work but asymptomatic for your institution?
Our institution, and I think there's a number of other institutions that did, they've instituted a 5-day Plaquenil prophylaxis. So there's some studies, a lot of this is not proven, but where they initiate hydroxychloroquine, 400 milligrams BID times 1 day, and then 200 milligrams BID times 4 days. That's not uniform, but there are, and there's obviously not a lot of great studies, but if there's something that we have that can potentially minimize the risk of, you know, the staff getting symptomatic or getting infected with COVID.
Are you still going in or checking fevers, reporting any of these things?
So I've, you know, they said that I should be checking fevers, but to be honest with you, I've been feeling completely fine. So again, institutional protocols vary, but the recommendations, I believe from the CDC, is that 72 hours without fever. And then you can come back, because the fact of the matter is, we know that as healthcare workers, we're at the highest risk of getting exposed. And as a result, if we did the full 14-day quarantine that's recommended, we wouldn't have any healthcare staff.
Right.
We wouldn't have enough. And so you just hope that you take full precautions, wearing simple masks, like we talked about, at all times when you're at work, to try to minimize exposure to other people. And then ensuring that, you know, you're wearing all correct PPE. Just on the topic of PPE, I think something that's really, really important for people to review is going to the CDC's website and reviewing proper donning and doffing technique. I think that's really, really, really essential. The donning part is not as big of a deal as the doffing part, because that's really where you're going to potentially contaminate and expose yourself. So you need to be just be very, very clear on those guidelines, on those protocols.
Especially with ENT, because we are not good at being sterile.
Yeah, I mean, you know, we take it for granted, and for this, you really can't. You really do need to take full precautions.
Excellent, excellent. I guess along the lines of testing, there's been some modifications here in the state of Kentucky where, I mean, it's even gotten to the point of drive-through testing at one of the outpatient clinics. So can you all touch on the testing and kind of the graduation or the improvements in them in terms of the time frame? And where are we now? How long does it take to turn around a test? You know, should we be doing this on all of our procedures or just the ones that violate, you know, nasal mucosa or nasopharyngeal mucosa? So where are we with this testing currently?
I think the main issue with different types of tests, now there's so many different private labs and state labs, and you know, every space you do a test in has different issues, is now kind of like people are talking about limits of detection, like how many RNA copies per ml, and we don't necessarily really know that. I don't know this necessarily talked about. It can be the order of like 10 to 100 or something. So every test you have to take with caution, but I think I've heard that the specificity and sensitivity of the tests are quite high, like in the 99% range. So it's a very good test. But like any test we do, it's only as good as the tester, the person doing it. So it's really important to get a sample from the nasopharynx. You may have inconclusive results, at least for the Kentucky labs. They were talking about how at our recent webinar, about how if there's not enough sample, then they will run it twice and then call it inconclusive. And inconclusive does not mean negative. It just means there wasn't enough and you have to do it again. You know, we have testing that can be done within a few hours, or there's also tests that are like about 3 to 5 days at outside testing that are for outpatients. I think at least, I mean, recommendations, it's always who would you ask. I think in practice, de facto, we're doing maybe trying to do one negative test before a risky procedure, but really it should be 2 separated by 24 hours is the correct way, because there's a lot of patients who are early on in the disease, maybe not shedding, but that's why they'll be negative, and then a few days later they'll be positive. And we see that anecdotally in cases in the media. So
one of the things that we're kind of struggling with in the head and neck, because we're still doing, I wouldn't say all of them urgent, but cannot wait type of head and neck cancer cases. And the question is, which part of the resources do we use? Do we say, okay, we need to have 2 negative tests, or do we have the full OR gear up and use full PPE for the entire, 8-hour case? And, again, not having hit our wave yet where we actually are facing true shortages, it can be sort of a daunting question, because, okay, well, are we putting everyone in the room at risk by basing this off of 1 negative test? Or are we potentially limiting our healthcare providers later down the road by using up PPE? And so right now, at least internally, and I know at Stanford as well, they're working on a blood test too that can be slightly easier, because a blood test is one that, it's hard to not get blood, depending on your veins, I guess. But with regards to the nasopharynx, the guidelines are to get to you put this, I don't know if anyone's had this before. I don't know if you got the pleasure of having one of these down your nose yet, but it's a swab that goes in all the way to the nasopharynx, spun for 20 seconds, and then they get one from the other side, spin for 20 seconds. But on some recommendations says just stop till you hit resistance. And as otolaryngologists, we all know that not everyone's nose is straight pathway. There can be a septal spur, there can be a big turbinate, there can be a polyp. And that can limit the sensitivity and specificity of the test if there's an inadequate specimen. And so that one's still kind of a question mark, that even now we've got a total laryngectomy total laryngectomy flap coming up on Thursday. And the question is, do we bother with testing? Because we only have time to do 1, because right now our turnover is about 24 to 48 because they're batching the tests. Or do we go ahead and gear up completely? And so, that's one of our questions. And Manoj, for your guys, from the testing standpoint, are they just testing then the symptomatic patients right now?
They are testing, from my understanding, ones that are suspected are getting tested. But the thing is, there's also just an assumption that everyone is COVID positive. So if we're doing any kind of urgent emergent case, it's definitely from an anesthesia perspective. If we're instrumenting the airway, we're doing rapid sequence inductions. We're not mass ventilating these patients. Most senior provider going in full PPE for that intubation until the airway is fully secure, at the very least. Because again, not everyone in the OR is wearing full PPE. I would assume that I haven't been in the OR because we've all taken separate roles now. So, but my assumption would be that the people that are at highest risk of exposure are the ones that are wearing full PPE, whereas other people are wearing, standard protective equipment and maintaining distance at all times.
So along those lines, recently we've been asked to do a trach change for somebody who wasn't tolerating a passing Muir valve. We have another case where a gentleman has quite a bit of comorbid conditions, and I guess the life expectancy is not long, and we've been asked to do a trach. So comments from the 3 panelists on those sort of situations, and I see Dr. Fritz is on too. So Mark, if you have any comments in addition to this after your recent publication, please feel free to chime in.
Don't forget to unmute. There you go.
Yeah. We just published some guidelines through the Airway and Swallowing Committee at the academy level. I think that email came out on Friday, just basically trying to give backup to providers, because this is a huge issue for doing a trach as well as trach care in this time, because I mean, any trach patient, as you know, like it's going to cough and be aerosolizing all types of stuff. It's no longer a closed system like an intubation is typically. I mean, for an intubation, it's the person who's doing the intubating, then pretty much it's a closed system afterwards, even for suctioning. So you don't expose the whole room to all these aerosolized particles. So I feel like it does need to be thought of very deliberately in terms of if the vent settings are worsening, if they are really requiring that positive pressure with a PEEP, if there's not a great prognosis, like delaying. And our guidelines basically, or recommendations rather, said to wait 2 to 3 weeks intubated time before you really think of doing that for a COVID positive patient. It's trouble when the patient is in the hospital already in this COVID pandemic. What do you do then? Do you presume they're positive? I mean, I did 3 airway cases on Friday and we presumed all 3 of them were COVID positive because they weren't going to test all 3 of them before the surgery. So it's tough.
One comment that I want to make just in terms of, Mark, what you were talking about is that it's a closed system until it's disconnected. If we need to suction and we want to go down the tube, obviously we have to disconnect and suction down the tube. So then at that point, it becomes an open system. And one thing that we're doing with a lot of patients, once we're extubating, we're actually clamping the endotracheal tube before we're removing it, so that if the patient coughs, they don't have a spray that potentially goes through the endotracheal tube and potentially could contaminate or hit somebody in the face, something of that nature. So that's just an extra step that we're taking.
That's smart. Are you doing that, or are people doing that in the operating room as well?
That's what I'm saying. Yeah, so it's happening in the ICUs, and that's how we are extubating our patients in the ORs as well. And I think I think a lot of places across the country are instituting that as an additional protection.
Are your colleagues also using glide scope and other ways that you try to avoid face-to-face contact with the mucosal surfaces? Yeah,
pretty much everybody that's getting intubated, like I said, it was the rapid sequence, and for the most part using some type of videolaryngoscopy, whether a McGrath, a glide scope, whatever is available. And again, the most senior person doing it so that you minimize time of exposure.
And have you had any experiences with people having sort of difficult airways where, you know, you're like, in real life, we would probably be doing like a flexible fiber optic intubation or an awake trach or something. Because here we're seeing, before all this happened, we were probably averaging about at least 1 awake trach a week, just from our cancer burden. And so that's another thing that, you know, again, not a closed system if you're doing a fiber optic or a trach, but I don't know if you have had any of those yet.
Personally, I have not. I think, again, that if that's going to happen, then if it's considered urgent or emergent, I mean, then it needs to get done. Then I think at that point, you absolutely minimize who needs to be in the room, and everybody that's there is wearing full PPE, and just taking the best precautions you can. I mean, the fact of the matter is we're not going to be able to prevent exposure. We're all going to get exposed just because of the nature of what we do. And so the only steps that we can take is making sure that we are minimizing the number of people who could get exposed, and those who are getting exposed, that they're fully donned in their PPE to protect themselves the best they can.
Are there any guidelines for your institution about what to do if you're working in these high-risk environments in terms of protecting your family or anyone at home? Are people staying elsewhere? I've seen some things about that, people getting Airbnbs.
Yeah, so New York, so the Four Seasons in New York, and I think a couple of other hotels have opened up their rooms for free to any healthcare providers that need them, so that they can maintain their distance from family. For me, I mean, I live by myself. Well, my cousin's here too, but he's, even at home, we're maintaining social distancing at home. And I was wearing a mask for a period of time also after I had my exposure, even though I haven't been symptomatic. But yeah, there's people that are living separately, asking their family members to go back to whatever their home is in quarantine. Again, I just always assume that I'm contaminated. It doesn't matter. I mean, we don't have full hazmat suits, so you can do as great of I mean, obviously, please still hand wash. Be really, really good about it. Any risk of any areas of exposure that you think you may have had, wash those areas. But the fact of the matter is you're still not going to be able to cover everything. So when I come home, like I take a subway, I mean, and just being in the hospital, I know that I'm exposed. So when I first come home, I minimize what I touch. You know, I immediately take off my clothes and I just go and I shower. And I think that that's kind of what needs to be done. I think it's really, really hard for people to social distance, especially when it comes to their loved ones. But I would really, really, really strongly suggest that happens, especially for people who are high risk, that are in the high risk population. In New York, it's so hard. I mean, you still see groups of people even in New York, even though we're the epicenter of everything. It's there's only so much you can control. So, but I would just say that for the sake of yourself and for your family members, to really strictly follow these guidelines, because we have a lot of patients that really don't really have any significant comorbidities that are getting really sick. And so, I mean, I'm sure you guys will go and talk about the symptomatology of COVID. Obviously the anosmia portion of it, which I think is actually super, super interesting, but I'll leave that to you guys.
I want to backtrack for just a second. We had a question come in from the gallery. It says, this is from Tyler in Atlanta. Has anybody heard about the test swabs breaking off during use? Called last week to come and help for this reason on a presumed COVID positive patient whose swab broke off in the nose. ED was able to get it out before I got there, but just wondering if anybody else had seen that.
No. Oh, that sounds terrible.
Yeah.
So they consulted ENT then for the.
That's what it sounds like. So.
And actually there's a guideline coming out. Dr. Baba Givi is out of New York, actually. It's not published yet, but they were talking about foreign bodies and which ones can wait if it's dangerous, that kind of thing. And so one of the recommendations that they actually mentioned was that if it's a foreign body that's not a threat to life or limb, that it's better to do it in a controlled negative pressure setting. So even if you don't necessarily anesthetize them, you bring them to the operating room where you have negative pressure and PPE to get it out. Because like, let's say it makes them sneeze and then they're expelling droplets all throughout the room. And so that's one of the recommendations that they actually were talking about, was like, you know, foreign body in the nose if it's a kid with a coin or a jelly bean or something like that. Lower risk if it's in the ear. And of course, normal foreign body in the airway or the esophagus usually goes to the operating room anyway. But that was one of their recommendations for nose, at least. But man, I'm sorry. I'm glad you didn't have to take it out.
One thing that I just want to comment is that in our pediatric population, you know, a lot of times what we do is we end up doing mask inductions for this patient. You have kids that are crying and screaming. And the thought process now about recommendations are potentially pre-medding all of these kids, making sure they're nice and calm, and putting in an IV prior. I don't think everyone is doing that yet. I think that we still are mask ventilating, but we're making sure that they're spontaneous, that they're calm, they're spontaneous, and that we don't bag mask them until we just don't. We get the IV, we secure the airway. So I just think in the pediatric population, it kind of provides a unique challenge in that sense, because crying, screaming kids are a big risk in terms of exposure. So,
are you all seeing a lot of peds presumed COVID or positive?
Again, every patient we're assuming is COVID. So, you know, everything has, with the pediatric population, you can't, you know, we use our HEPA filters. We use filters pretty much everywhere that we can. But if you look at the diameter of what can be cleared by those filters, the filter is still not small enough for the virus. But again, you're trying to just hope that you catch major droplets and to prevent spread. But at this point, especially with the whole pandemic, you almost have to assume that a lot of things have been contaminated already, and they were unknowingly contaminated. And so you just make the best with what you have.
And have you had any kids needing to be intubated in your hospital, or is that going to like New York Children's or?
No, we have our own pediatrics division. So if there was any pediatric cases that needed to be intubated, they would be done. They would be done at NYU or at my institution.
At institution. Otherwise,
but no. But the youngest, I haven't heard. I've spoken to a lot of my critical care colleagues, and I haven't heard of anyone less than 18 specifically being infected so much that they've needed intubation.
So let's switch gears just a little bit here, and can our panelists talk about some of the signs, symptoms? You know, the anosmia is obviously a big one. So what are your thoughts on that? What's the data most recently saying regarding this?
So, and Manoj maybe knows some of this too, but it's about a 5-day lead-in. Those 5 days when someone's been infected is one of the times when they can be an asymptomatic shedder. But anosmia is one of the presenting signs, but then also conjunctivitis has been listed as one as well, which unfortunately is sort of coinciding right with allergy season when people tend to get anosmia and conjunctivitis. And typically these early signs can also be in line with a little bit of GI disruption. So some people present with vomiting, diarrhea, feeling queasy, and then that progresses to the normal flu-like symptoms where you're getting myalgias, fatigue. There have been some reports that in the older population, you'll get actually a lower temperature as opposed to so 98.5 is sort of this not arbitrary, but it's one that was sort of taken as an average. But some of the older population, like above 70, are presenting with temperatures like 96, which is a little bit strange. And then, but even low-grade fevers of like 99 to 100, which usually we sort of shrug off as not really a fever. And then progressing from there to worsening chest discomfort, cough, which is typically dry, not productive. And then one of the things that I thought was kind of interesting for people who are quarantining at home, and Manoj probably knows more about this part, but actually turning prone on these patients, even before they get to the hospital, if they're starting to just feel chest tightness, a lot of times they're reporting that when they lay on their bellies, they actually feel better, that they're oxygenating slightly better. And Dara Cass, who's an ER physician in New York, recently was tested COVID positive and was pretty symptomatic. And so she said, I can tell when I lay on my belly, like I feel better. And so that's kind of the progression, and then getting to the point where you feel very hypoxic and struggling to breathe and drowning and feeling like you have to go to potentially intubation. So I don't know, Manoj, you may be able to comment on when are people coming in? Because I know you're gonna have the people that are like, I'm afraid, I wanna come in, I wanna know my status, to I need to have my tube put in yesterday kind of deal.
Yeah. Sorry. But what I would say is this, is that, you know, because I've had a lot of friends, I know personally many people that seem very symptomatic. They have symptoms that are very consistent with COVID. And I specifically tell them, do not go to the ER unless you are short of breath. Because all you're going to do is potentially risk exposing yourself. And if you are positive, also exposing a bunch of people for mild symptoms. So that's pretty much the recommendation, I think, across the country, is feeling symptoms, quarantine, isolate for 14 days. And if the symptoms progress to the point of where you're getting short of breath, then go to the ER at that point. Because then at that point, you might be in the process of deteriorating, and you want to obviously make sure that you're in a place where somebody can manage you. But what you were saying was, you know, I've seen a lot of it where the initial presenting symptoms tend to be, like you said, just the GI symptoms and the anosmia. I just have a friend this morning who texted me. She said, I haven't been feeling well. I can't smell or taste anything, and I'm not eating. And I'm like, you need to isolate. So yeah, I mean, that's pretty much the situation. I tell everyone, like, don't panic, because I think there's a lot of panic around with COVID-19. you know, even if you're at high risk, again, I still say if you fall within the high risk population, still stay at home until you feel that, you know, it's getting to the point of where you're deteriorating and it is getting a little bit harder to breathe. I'm not saying you should wait till you're suffocating or drowning, but if your cough is progressing to where like I'm not feeling like I feel like it's a little bit harder for me to breathe, then at that moment go to the ER.
And I think that's one of the things that we may be able to help with from a telecare or telehealth standpoint is reassuring people. We're trying to go live, and I don't know if some of the other institutions can chime in yet of what they're doing yet. But I think that even just having like a way for someone to check in and say, hey, I have these symptoms. Should I come in? Can I wait this out? What should I do? Should I be taking my temperature every so often? So I don't know if any of the other folks who are on the line have been doing anything like that just yet. I have a friend who's actually in New York who works for a startup, and they're working on getting going live with that kind of information too, to have just so someone can talk to somebody, to have a, you know, face to face, if you will.
I think at our, you know, I'm not 100% sure, but we have our pre-surgical testing clinic, where obviously we're not seeing a huge number of patients for like their elective procedures that are coming up. But they're still doing a telemedicine, and I believe that one of the points of doing those telemedicine interactions is purely just to comfort patients that have concerns secondary to those kinds of infections or to symptoms associated that could be potentially COVID. I think reassurance, like you said, I think reassurance is a really, really big thing. And some of the symptoms can be pretty bad. It can wreck you, and you may feel, based on how awful you feel, that you should go in. But again, unless you're feeling short of breath, it's a big waiting out process.
I was just talking to some friends from New York yesterday, and they were saying that you can't really get Tylenol anywhere. And I know kind of on the blogs and Facebook and stuff, there's talk about like you shouldn't use ibuprofen, but maybe there's not data about why, or if maybe that's wrong. Has that been an issue for you all for when you're trying to treat people at home or have people stay at home?
Yeah, you know, I guess there's just a lot of conflicting data. There's really, and when I say conflicting, there's really not really any data that says that that you should. I mean, it's a recommendation based on theory, but nothing actually specifically confirmed. So a lot of the recommendations that I've seen have been that if you can get access to Tylenol and you can use it, you know, but if you need to use ibuprofen, then use it. If you've been on chronic NSAIDs, continue to use it unless you talk to your doctor. So there's, I mean, I just took 4 ibuprofen this morning because my shoulder hurts. You know, I'm not going to say yes, everyone, that ibuprofen is 100% safe, but I would say that the data doesn't bear out at this point that it's unsafe. So take that with a grain of salt.
And similarly, I think I said stuff about ACE inhibitors. At least the patients are in the hospital having trouble, they're taking them off. But I guess if people are on chronically without symptoms, to stay on. Is there any updates about that from you all?
Again, it's what you specifically said. I think that you know, there's thoughts in terms of, you know, upregulation, changing the receptors, you know, giving more binding sites for the virus itself. But we're not trying to make big sweeping changes specifically on patients. I mean, I think that if you can safely convert them from an ACE inhibitor to something else, that you do it, but not every patient falls within that category.
So I want to go with one more question for the panelists here, and then we can open it up for just a few minutes to the audience if there's any more questions out there. Time's actually getting short. It's been great discussion. So what about middle ear or mastoid surgery? You know that our chair has been quoted as saying the ear is just an extension of the sinuses, which I love. You know, you'd presume viral particles or else otherwise can crawl up there. So any recommendations yet that you have heard of?
Dr. Jackler from Stanford I think through the Academy, put out some recommendations, but they're all theoretical. But it's exactly what you said. It's all, you know, unified airway and all connected. That's a mucosa. So I think it's the same idea, that test if you can, limit doing the procedures if you don't have to.
Especially
check yourself if you do.
Good.
When you think about drilling and irrigating, I mean, all that stuff could
spraying everywhere.
Yeah.
Sure. For any audience members out there, if you have any questions, you can either do the chat, or if you want to unmute your microphone. We've got a few minutes for the panelists here, and then once we're done with that, I'm going to do a brief discussion regarding the reason for starting these consortiums, and then we'll move on to Dr. Fritz at 9 o'clock. So, any questions out there from the audience?
One quick comment that I want to just make is, and I've been noticing this because I've been watching myself on the video, about the number of times I touch my face. So, you know, we all touch our face. I think they say that the average is about 20 times per hour. And, you know, when you're talking about specifically it originating in the nasopharynx, you have risk of conjunctivitis, just like Alex was talking about. Just being very cautious, like I'm being cautious of that. I mean, I washed my hands earlier today. But just being cautious that after you've been dealing with patients, or you potentially have any kind of exposure, touching anything that's in a public area, that you are being conscious about not touching your face, washing your hands immediately so that you don't potentially spread it to yourself.
And then I don't know what the official recommendations, but I've heard also to maybe avoid contact use, the contacts, like the eyes, just because it is a potential spot that can get contaminated and then just sits on your eye all day long. And then if you don't have daily disposables, then you're putting it back in every day.
Yeah,
Right.
we talked a lot about ENT, but ophthalmology was the other specialty, at least then showed in Wuhan, was a very high risk of getting infected. So that's an important point.
Okay, well, I want to thank the three panelists. This is great information. And Dr. Domia, if you don't mind, we may ask you back in a few weeks once some things have kind of progressed. This is great to have somebody who's on the front line, so to speak, to give us a viewpoint of what's going on. And certainly we may reach out elsewhere across the country as the COVID-19 spreads kind of from the coast inward at a more rapid rate. Dr. Gupta, Dr. Keckner, thank you very much. I'll be seeing you around. I'm going to transition now just briefly for those listening to kind of the thinking behind the starting of the consortiums. And then again at 9 o'clock, we'll get Dr. Fritz going with his talk on chronic cough. So the consortiums, there's 3 consortiums now. If you've been on our website, you're fully aware of this. And for a long time, there's been discussion about potentially having a national otolaryngology residency education curriculum or platform. And we, Dr. Gupta and I in our department, we quickly realized that if what I call COVID-induced limitations, or CILs, continued for an extended period of time, we were going to quickly exhaust not only our lecturers, but our lecturers. We had made a decision to go to 3 to 4 hours per morning of lectures while our residents have been platooned. We have 1/3 of our residents at home, 1/3 on the head and neck service, and 1/3 on the general ENT/pediatric service. That's a big change from our normal rotations. And we made this decision to kind of quarantine each group from each other, so that if one platoon went down, so to speak, from illness, that we still had backups. Well, the byproduct of this is, particularly for the people who are at home and with the reduced clinical volume, we needed to still be able to educate our residents. And so therefore we went to Zoom-based learning, as did many other institutions virtually simultaneously. With regards to the consortiums, they started almost synchronously. The West Coast started just about a week ago today. Dr. Mowry started the Great Lakes Initiative Friday afternoon, and then we've got ours going today. And you know, I think all 3 groups of leaders for the consortiums could say, we just want to educate you as residents. This is an unprecedented time, and we're learning as much going into this as you are hopefully learning. And again, the need to develop a national curriculum. This idea has been discussed for years at national meetings, and this COVID issue may have forced our hand. So again, there's the 3 consortiums. If you go to our website, there's links for each of them as well as contact information. And just because you're engaged in one consortium or live in a particular area doesn't mean you can't participate in the others. I fully realize right now on the West Coast it's really early. However, theoretically, West Coast people can be watching or participating currently. Likewise, with the Western Consortium that's late in the evening for those of us on the East, folks from the East Coast can participate in that as well. So long-term plans, and these are pretty much my thoughts. We're currently in discussion with the other leaders of the other consortiums, but to try and organize the curriculum. So for example, that you don't get between the 3 consortiums, you don't get 5 lectures on head and neck one day and then don't see a lecture on head and neck, for 2 weeks. We want to sprinkle in some professionalism and wellness topics. In our consortium, we've got some audiology going on as well. This, I believe, could easily be done on a unified Google spreadsheet that can be linked to all 3 websites. And then if the CILs continue beyond the start of the 2021 academic year, I think it's going to be critical that we get lectures from colleagues like Dr. Dalmia and critical care, because we're going to have a bunch of interns coming in who don't have necessarily much surgical management experience, and we're going to need to know about volume resuscitation and ventilator management and pressor management and all those sorts of things. And so I think that's going to be a critical next stepping stone, if you will, to this consortium idea, depending on if this continues. Furthermore, this can serve as a blueprint for a national curriculum. I'm working with the other leaders furiously on this, just submitted a document to them this morning. And then, for long term, as presumably the COVID activities kind of ramp down, and that means clinical activity is going to ramp up. I'm going to have to go back to my day job at some point, and we may need to end up transferring this to a major national stakeholder or something of that effect. We've gotten a lot of questions out there. I've gotten a few via email over the weekend from residents who are listening. Are these lectures going to be available recorded? The answer to that is yes. There is a lot of data storage issues going on with that, as well as intellectual property issues with that. So the answer is they will be available. We're just not quite sure how yet. I'm hoping to get a conference call with the other consortium leaders sometime this week so we can sort that out. Again, we're kind of learning on the fly here. For 2 of the consortiums within the last week, we built websites within 3 to 4 days. So that's relatively quick to get this going. So anyway, we're almost at 9 o'clock. I'm going to